Now we will discuss the clinical features of cirrhosis. So all these are clinical features of cirrhosis, and as there are a lot of them, so most students forget all these. But if you see this small illustration, then this illustration will help you to remember all these features of the cirrhosis. So let's start. Firstly, some patients of cirrhosis might be asymptomatic. Secondly, some patients might present with non-specific symptoms of weight loss, anorexia and fatigue. You know that cirrhosis is caused by chronic liver disease, and all chronic diseases can cause this weight loss, anorexia and fatigue. So the patients can present with non-specific symptoms. Now for other main features of cirrhosis, you have to consider this diagram. You know that gastrointestinal tract, liver and gallbladder are all intimately related. They are connected in a way that the whole blood from the GIT is directed to the liver through this portal vein. So you can consider the portal vein as the main input channel of the liver. Secondly, this liver secretes bile and bile salts that are secreted through this bile duct into the gallbladder. So you can consider this bile duct as the main output of the liver. Secondly, these cells of liver that are hepatocytes themselves perform various metabolic functions. So you can consider these hepatocytes as the central processing unit. So you can compare the functioning of liver with a computer that has an input device, an output device and a central processing unit. So similar to that computer, our liver has an input in the form of portal vein, has a main output in the form of bile duct and has hepatocytes that perform the central processing. Now let's discuss this in a bit details. Now let's start with this input of the liver. So the input to the liver was coming from GIT through these portal veins. Now this portal vein entering the liver divide into small capillary-like channels that are known as hepatic sinusoids. Now what happens that in cirrhosis, the development of fibrotic scars in the liver compress these hepatic sinusoids. And as these hepatic sinusoids are being compressed, so there is congestion and increase in pressure of blood in the portal vein. So the pressure in portal vein starts to increase. This is known as portal hypertension. So the portal sinusoids are compressed in cirrhosis to cause portal hypertension. Now when these hepatic sinusoids are compressed and there is resultant back pressure or congestion of blood in the portal vein, then this will cause congestion of blood in the organs of GIT. And there is one organ of GIT that contains a lot of pulp in the form of white pulp and red pulp. And due to the increased quantity of pulp, that organ can assume enormously large size. And you have already guessed that this organ is spleen. So spleen can undergo the congestion of blood and can increase in size. So you will see congestive splenomegaly as a consequence of portal hypertension. Secondly, as the portal pressure is increased, so the portosystemic anastomosis present in the GIT get enlarged, and this can result in the formation of esophageal varices, and these varices can also be present in the other areas, for example in the anal canal. But the most significant are the esophageal varices. These esophageal varices can rupture to cause upper gastrointestinal bleeding. Thirdly, this congestion of blood in portal vein can cause ascites. But ascites is a multifactorial disorder that will be caused by other pathologies also. We will discuss the ascites as a separate topic. So remember that from the input part of this diagram, that when the portal vein or its branches hepatic sinusoids are compressed, it results in portal hypertension that causes congestive splenomegaly, esophageal varices, and it may cause ascites. Now let's come to the output part of this diagram. So we discussed that the main output of liver pass through these bile ducts into the gallbladder in the form of bile. So what happens is that when fibrosis or scarring starts to develop in the liver, then this fibrotic tissue compresses the biliary canaliculi that are present in the liver. So when the intrahepatic biliary channels are compressed, you can consider or imagine that bile will not be secreted properly through this bile duct into the gallbladder. Now what happens is that when bilirubin, bile salts or bile acids are not allowed to enter into the gallbladder, they regurgitate into the blood. This regurgitation of bilirubin in the blood causes yellowness of skin and sclera or yellowness of the body, that is known as obstructive jaundice. So due to the compression of these bile canaliculi, you will see obstructive jaundice. And as bile salts and bile acids are not being properly secreted, so these bile acids or bile salts will also be regurgitated into the blood, and these bile acids or bile salts can deposit in the skin, and when they deposit in the skin, they cause an intense sensation of itching. This intense itching is known as pruritus. So along with obstructive jaundice, you will also see pruritus. Now let's discuss this central processing function of hepatocytes. So the function of hepatocytes is in two ways, that they perform some synthetic function and they perform some degradative function. Now their synthetic function is manifested by the synthesis of two main proteins. One is the albumin and the second is clotting factors. Now as the hepatocytes are now being destroyed and are continuously being replaced by fibrotic tissue, so this compromise of hepatocytes will result in decreased synthesis of albumin, that is known as hypoalbuminemia. This decrease in albumin in blood can cause edema in whole body, and this hypoalbuminemia can also aggravate the ascites, that is caused by portal hypertension. Now other than albumin, the liver cells also synthesize clotting factors. So the deficiency of clotting factors can result in coagulopathies, which can cause hemorrhages. So the synthetic machinery can be destroyed, resulting in hypoalbuminemia and coagulopathy. Second important function of these hepatocytes are degradative functions. So the first degradative function is that liver detoxifies ammonia to a less toxic form, urea. But as the function of hepatocytes is now being compromised, so there will be increased level of ammonia and other nitrogenous waste products in blood. This ammonia and other nitrogenous waste products disturb the functioning of neuron. This causes a sensation of delirium or disturbance in the neuronal activity, that is known as hepatic encephalopathy. So hepatic encephalopathy is the disturbance of neuronal function secondary to the liver disease. Another degradative function of these hepatocytes is that they degrade a sex hormone known as estrogen. So this compromise of hepatocytes will result in increased quantity of estrogen in blood, that is known as hyperestrogenemia. Now what does this hyperestrogenemia cause? Firstly, you can imagine that in males this increased quantity of estrogen in blood will result in hypogonadism. So in males this estrogen causes hypogonadism, but in females also this increased quantity of estrogen can cause hypogonadism. Why it causes hypogonadism in females? The answer is that that estrogen exerts a negative feedback on the secretion of FSH and LH from the pituitary. So due to the increased quantity of estrogen in females, this estrogen will negatively regulate the secretions of FSH and LH, and as these hormones are very important for the development or maturation of the ovaries, so the ovaries will decrease in size, resulting in hypogonadism in females also. Now other than these, estrogen can also cause palmar erythema. Palmar erythema means increased redness of the palms of the hands. Why does this occur due to increased quantity of estrogen? It is unknown, but still you have to remember that estrogen can cause palmar erythema, and this estrogen can also cause spider angiomas on the trunk of the body. Now what are these spider angiomas? These spider angiomas are actually red color dilated capillaries that have extensions that resemble like the legs of spider. So these spider angiomas can be present on the body, more so on the trunk. So all these are secondary to hyperestrogenemia. Now let me revise all the clinical features of cirrhosis. I hope that now you will easily remember all these clinical features. From the input, we came to know that portal sinusoids are compressed, resulting in portal hypertension, and this portal hypertension can cause congestive splenomegaly, esophageal and other varices, and ascites. And one point which I forgot to tell, that in portal hypertension, along with these esophageal varices, there is distension of abdominal veins in the skin of abdomen that are known as caput medusa. So this caput medusa can also be present. Other than this, the output function of liver is compromised by the compression of biliary tracts. This results in obstructive jaundice and pruritus, and the central processing function of hepatocytes is compromised in such a way that the synthesis of albumin and clotting factors is decreased, resulting in hypoalbuminemia and coagulopathy. And the degradative function of hepatocytes is again compromised, resulting in increased quantity of ammonia and nitrogenous waste products in blood that cause hepatic encephalopathy. And the degradation of estrogen is also compromised, resulting in hyperestrogenemia. This increased quantity of estrogen in blood can cause hypogonadism in males and females, and it can cause palmar erythema or spider angiomas on body. So these are all the clinical features of cirrhosis. Now one important point to remember is that in cirrhosis, along with other than these clinical features, the cirrhosis can cause cancer in the liver, that is known as hepatocellular carcinoma. You know that we discussed in our general pathology in the concept of neoplasia that inflammation is an enabler of malignancy. So the inflammation that is occurring here in the cirrhosis can result in hepatocellular carcinoma. Now we will come to the topic of diagnosis of cirrhosis. So the gold standard of diagnosis of cirrhosis is biopsy and microscopic analysis. But nowadays this biopsy and microscopic analysis is usually less performed, and usually we diagnose cirrhosis based on these clinical features and investigations that favor these clinical features. Now, what are these investigations? You can learn all these investigations through this diagram. So for example, we discussed that in cirrhosis there will be hypoalbuminemia. So you will check levels of albumin in blood, that will be decreased. For coagulopathy, you will check PT, PTT, etc. that are prothrombin time and partial thromboplastin time. All of this will be increased due to the deficiency of clotting factors. Secondly, for encephalopathy, you will measure the level of ammonia in the blood, which will be increased. For hyperestrogenemia, you can check the level of estrogen in blood, that can be increased. For obstructive jaundice, you can do the complete workup of jaundice, that includes bilirubin, direct bilirubin and indirect bilirubin. Other than this, you can also check GGT, that is gamma glutamine transferase, and ALP, that is alkaline phosphatase. GGT and ALP are increased in obstructive jaundice. Now for portal hypertension, you can measure the portal pressure, but this is usually not done. Other than these, you know that all these clinical features were caused by the injury to hepatocytes. So the injury to hepatocytes can also cause increase in quantity of ALT, AST. So you can also check ALT and AST that might be raised in cirrhosis. But in some cases of cirrhosis, when there is too much fibrosis in the liver, the ALT and AST might not be raised to a very large extent. But still you can check ALT and AST. They are usually increased in some cases of cirrhosis. So this concludes all the pathology of cirrhosis.